Welcome to The Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm your host, Dr. Andrew Wilner. Today, I have the opportunity to chat with Dr. Steve Moffic, a psychiatrist and writer. I connected with Dr. Moffic through a mutual friend, Dr. Ronald Pies, also a psychiatrist and writer. Dr. Pies and I had a wonderful conversation on episode number 63 back in July. Dr. Moffic was designated a hero of public psychiatry from the American Psychiatric Association and has written regularly for Psychiatric Times. He is also the author of The Ethical Way: Challenges and Solutions for Managed Behavioral Healthcare. So I thought that was a very timely book. And here's the blurb from Amazon. This imaginative book is a fictionalized account starting up a managed behavioral healthcare company in a highly ethical manner. Leads you through a dramatic maze of ethical principles and crucial issues confronting mental health professionals in the new era of managed care. And I thought, how timely. And then I saw, when was this book published? 1997. So how prescient for some of the problems that we face. Now, I can't wait to speak with Dr. Moffic, but before we get started, I'd like to thank our sponsor, locumstory.com. If you're considering locum tenens, either full-time or on the side, you probably have a question or two, or 20. Fortunately, locumstory.com has the answers you need. It's packed with unbiased information and advice from physicians like you. Locumstory.com has nothing to sell. It's simply a resource for information. You'll find super handy tools that let you see locums trends for your specialty, compare different locums agencies, and there's even a quiz to help you decide if locums is right for you. Locumstory.com is the perfect place to start if you want to learn more about locums. And now, Dr. Moffic, welcome to The Art of Medicine.
Thank you, Andy.
Dr. Moffic, well, let's start. How do you and Ronald Pies know each other? Because that's how we got connected. Dr. Pies and I have written articles together. I've interviewed him, and somehow he thought, or I thought, that you would be a great guest. So what's the connection?
Well, I always try to stay on Dr. Pies' tail. He's one of the great psychiatrists in the country, really, as you probably know by now. And we have some similar interests in ethics, our Jewish background, etc. And how long ago now? Maybe a couple of years before I retired from clinical work, 10 years ago, he was editor of Psychiatric Times at the time and asked me, we're going to start a series of blog writers. Do you want to be one of our first blog writers? I wasn't even sure what a blog was at the time, but I said, yes, just tell me what I should do and I'd be glad to try it. And we tried it out. And I think my first one was on climate change way back a dozen years ago, becoming worried about that and becoming more of an activist. And then afterwards, maybe I wrote one a month or so. And after I retired, my writing actually escalated to more frequently, and there were new editors, both editor-in-chiefs as well as editors who would look over your writings and so forth. And now I write for them virtually every weekday. So he really got me involved. I for anything that I write that somebody doesn't like, I say, just blame Dr. Pies. He's the one who brought me on to do this. So
yeah, and wait for the next day because there'll be something different.
Yes, exactly. So it's actually been a great experience. I think Psychiatric Times probably is the largest psychiatric mental health publication in the world, and their editors are just terrific, and they're open really virtually to any topic. Kind of stay away from the most controversial political topics in society, but otherwise they're very open.
You know, I'll have to look at my resume, but I think I wrote for them too. For quite a while, and that may be where I crossed paths the first time with I worked for 10 years as a freelance writer not practicing medicine before I went
Oh,
back to practicing medicine full time. So I wrote for every what they called throwaway in those days, the big
yes.
format, Psychiatric Times, CNS News, Neurology Reviews, all of those. But Psychiatric Times has survived.
Yes.
And I didn't realize they were so successful. So that's great. So are you still writing for them?
Yes. So now I'm on the editorial board, and writing wise, I do, well, one of them is a video actually. So since about a year and a half ago, maybe 2 years, I started to do a once a week video on psychiatry and society. The reason being, COVID was going on at the time, and there was all sorts of psychological repercussions with that, with racism after George Floyd was killed, etc. So we started this once a week video. It's still going on, and I think there's been 100 of them so far, over. And then, because those issues were even becoming more frequently, I was asked, can you try to do a short daily, weekday column and title it something like Psychiatric Views on the Daily News? And that's what I've done. So Monday, Tuesday, Thursday, Friday, I write that column about various social psychiatric issues, 500 words or less. I thought that wouldn't last very long. I didn't think probably I would be inspired so often, or that I was hoping the social psychiatric issues would get better and we wouldn't have to cover them, but they've actually gotten worse. and so it goes on. And it's been just a treasured experience for me. And again, they have such terrific editors to work with. It's a pleasure.
Well, one of the things that I have the opportunity to do on this program is bring on guests who've written a book or who are writers, because, well, that's something that I do. I've published 4 books, and I'm always trying to write the next one, and lots of articles. But the whole concept of writing, and so I'm going to ask you some questions that people ask me and that I ask myself. So the first question is, why? Why
Yeah.
get up? Because it's not easy. You said, oh, it's just 500 words, right? But I bet that 500 words takes longer than an hour.
Sometimes. Sometimes it takes many hours. Sometimes it comes right off the top of my head. Often if it's as if I'm a vessel, the topic comes somehow out of the blue, or something I read, and okay, this is what you're supposed to write about. And sometimes that's easy, something not. Why I write in general, that's sort of a psychiatric question, and I'm not sure exactly how to answer it. I'll give you a few signposts along the way. Often I think back to grammar school, and I had this terrific, demanding English teacher who told me, you can write well, but you've got to do this and this. And that meant be more concise, watch your grammar, and so forth, but try to keep writing. I didn't do much writing then, and it really didn't come to pass again until I was a sophomore in college at the University of Michigan, and I decided to take a creative writing class. And I had just met my future wife, and I wrote a story about meeting her. And that became important between us and sort of inspired me to think of writing more. But then medical school came. But I did a little writing on the side besides that. I had become interested in jazz music. And I thought, if I didn't make it in medicine and psychiatry, I would write about jazz. And so I wrote a bunch of record reviews at the end of college and the beginning of medical school. So I kept that up. And finally, I decided to go into academic medicine and academic psychiatry. And I knew I had to write. It's, publish or perish kind of thing if you wanted to stay in academic medicine. And so I almost had to write because I had to. I didn't really love that kind of writing, the kind of writing that would qualify for academic advancement. But I did it anyways. The kind of writing I liked more was more kind of free form. I liked writing letters to the editors of newspapers, that sort of stuff. But I did that stuff and edited a couple of books, wrote one book about managed care along the way. And so I did it, but I didn't love it. The writing I do since I've retired, I love. So I know what I really like to do. And if I have to do the other kind of writing for one reason or another, the more formal kind, fine, I can do it. It's just not, it's not the same for me emotionally.
Oh, yeah. I think, it's when people talk about writing a journal article, I always bristle when I hear about the literature of medicine. It's like,
Yeah.
this is not literature. This is not literature. These are case reports, these are reports of studies. They're very formulaic.
Yes.
You just kind of put the numbers in and follow the format. I mean, it is a kind of writing, scientific writing, technical writing, but it
Right.
doesn't have a lot. I mean, except that you're typing, doesn't have a lot to do with fiction writing or commentary. I wrote a book called Bullets and Brains, which is all commentary. Just like you said, something happened. There's a new drug approved, and for example, there was this new Alzheimer drug. I didn't write about that, but that's the kind of thing I would write about. It's like, well, what's the deal here? Does this drug really work? Should I prescribe it or not? And then kind of get into the details. But I'm really impressed that you can do this on a daily basis, because for me, 500 words could take all day very, very easily. And that's pretty impressive. Would you like to talk about your book for a moment and the issue of ethics? Because Dr. Pies and I wrote about ethics, and ethical questions that came up at the hospital. And there was just actually yesterday, there was a letter from a physician who lives in my city. She's an ER doc, and she was writing because Blue Cross Blue Shield, which employs her and many, many other ER docs in a company, as of, I think, January 1, was cutting their reimbursement by 40%.
Mm.
And she said, we have been risking our lives to save patients during the last 2 years in COVID. We've been short-handed. And now, all we want to do is care for patients, and the insurance company is pulling the rug out from under us. Our rates are already lower, she said, than anyone else's, and now they're being cut by 40%. What's the goal here? Do you want us all to quit so that, you can just say there's a doctor shortage and, hire nurse practitioners? What's the end game here? And why is this happening? And of course, it's going to deprive people of care. And so hence, it didn't, on the face of it, it didn't seem ethical. Let's put it that way. Now, what were the ethical issues that you were addressing in managed care?
You mean follow the money is not ethical? I mean, that's the essence of all this. For me, this started when I moved from Baylor College of Medicine to the Medical College of Wisconsin in 1989. That was for family reasons. My parents were getting sicker. And the medical school there, the Medical College of Wisconsin, wanted to go into managed care because that was a new system. And we in the department were the guinea pigs. So I was asked, can you set up a managed care system, not for profit, obviously, and let's see if we can make some money or lose some money, whatever. You'll kind of be the first in the medical school to try that. And I asked my collegial friends and mentors and stuff, should I do this or not? And the responses were sort of split. You're crazy, or go for it. So I decided I'm kind of experimental. I said, I'll try it. And I did. And lots of controversy in the department and outside along the way. So maybe a few years later, I was called by the editor at Josie Bass and said, my cousin Jim Sabin's a psychiatrist, and he's also one of the greats, recommended me to ask you to write a book about the ethics of managed behavioral health care. Would you? Can you? And he had me send him some like introduction to the book, which ended up being titled The Ethical Way, Challenges and Solutions for Managed Behavioral Healthcare. Came out in 1997. I did it. I did a conceit of a mock managed care company that was sort of like our own. And it had commentary at the end by lots of people. It's been reviewed like 3 different times since 1997 because all the issues are still there. And the most troubling one really is what you started with, is the goal of the managed care companies. And by the way, the word managed care isn't used anymore. It's a dirty word, but it still exists. Is the goal of these businesses to make money, or is it to provide quality of care, or both? We know the profits of some of these for-profit companies are enormous. And like the example you left, the reimbursement for physicians, especially psychiatrists, go down and down. Our own company, and I talked about this in the book, proved you can do this both to save money and improve quality and care. The outcomes of our patients, when we were being compared to the public system, were better, and we saved money both. So it can be done, but our goal wasn't to make a fortune. It was to survive and be a teaching kind of system. And I can tell you some horror stories for me. Just one of them was we were having a local Wisconsin conference about new things going on in psychiatry. I was on the committee that put it together, and one of the topics was managed care. So we invited the president of the American Psychiatric Association. He starts off with his address and says, Dr. Moffic is evil. Why? Because he hated managed care. He thought anybody involved with it was doing the wrong thing, and they were, quotes, evil. Now, I got a lot of support from the audience against that, and he later apologized to me, although only privately, not publicly, but that's the kind of stuff I confronted while doing this. And I actually stopped doing it when I retired from the medical college, but it was quite an important experience because the other side of the coin, besides the money, is the quality of care. And really, there's so much data out there that quality of care is not great all the time. You know, maybe a third of patients improve, 30% maybe stay about the same, and then a whole large percentage don't get better or worsen. And I used to get submissions over and over. Why are you doing this? I would ask. And they said, well, I've always done it this way. Well, maybe that's not the best way and not the best way to make use of your time and so on. So it's both quality of care and financial stuff that are the 2 overlapping challenges.
I remember I was a young neurologist, and I remember hearing about managed care, and it was sort of sold as, providing a medical home, and we're going to look after the patient from birth to death. And it all made sense. But then, from an ethical and physician and caring point of view, but then the other side, all of a sudden we were contracting with something that was called capitation.
Yeah.
And, I was not an ethical expert, and I was pretty busy, but somehow it's like, this doesn't make sense to me. It's like, we're going to get X number of dollars, and not too many dollars, say $100 per patient per year and it was a population of patients. And it's like, well, what happens if somebody needs, a lot of MRI scans or something? It's going to cost, $10,000. And then, and we were paid with the money left over. That was the way it worked. I said, well, this makes no sense at all, because every single time you order a test, you're confronted with this, gee, this is money out of my pocket. Well, of course, that was the design. That's why they did it that way. But as a physician, this was obviously the wrong I guess there is right and wrong in the universe. I'm convinced this is the wrong way to go. And I think, I don't know if capitation still exists, but it was an obvious, money-making experiment, not designed to improve quality of care.
Yes, sort of. I mean, our first contract was a capitation one. I think way back then it was $5 per member per month.
Okay.
Now, the justification, just psychiatry. So the justification for it, this is the amount of money being spent in the public sector right now. You will transfer to a capitated contract for you. And so you ought to be able to do at least as well as they've done. I said, okay, that was an interesting challenge. I put myself as the medical director as one of the clinicians, so I knew what it would feel like. And we reviewed everybody's care along the way. Now, one advantage was psychiatry doesn't have a lot of tests, right? So you don't have to worry so much about getting that approval. What took our money was inpatient hospitalization.
Hospitalization, sure.
So third day, for instance, I get called, we have a patient with schizophrenia in the hospital. And we ask, how long do you expect to keep them? And they might say weeks. Well, why weeks? And they couldn't explain it again. This is what we always do. And I said, well, we'll review how you're doing in a few days. In the meanwhile, our manager in the department said, you better watch this. I don't want to lose money. And so we would have to negotiate with them. Why do they really need to stay in? And over time, the length of hospitalization for patients like this in psychiatry dropped from weeks to days, as it is now. And it's really insufficient because we don't even have the outpatient services to pick up these patients adequately. And that was really the ethical issue. It was more like, how do you decide what adequate quality of care is for the psychiatric patients? Not ideal, because we never had anywhere close to the amount of money for ideal care, but what was adequate and how do you monitor that? And that's what intrigued me about it. But, the companies themselves, for the most part, their major goal was making money, not the quality of care. And that's the dilemma we're in today. It's because it's still going on. And of course, we don't have a national system of care. So it's like a free for all now.
Right. So just so people don't misunderstand, those watching on YouTube and listening on your favorite podcast player, I'm not against systems earning money, insurance companies, and sometimes that can lead to better care by eliminating unnecessary tests or extended hospital stays. I mean, that's not good for the patient. But I remember when I would often get these calls, Dr. Wilner, how long is your patient going to stay in the hospital? And my answer was, as long as they need to stay. And they didn't like that, but that is the right answer. When they're ready to go home, they will go home. And, for each patient, that is a very complex decision that has to be individualized. And you can't just say, oh, they had their appendix out, they stay 2 days. They had a baby, they stay 2.5 days. They had cardiac surgery, they stay 7 days. Certainly there are averages, but when you have a physician-patient relationship, that's one-on-one. And the averages aren't that important. So that's my position. So let me ask, did you come up with an answer? Because as you say, it's a free-for-all now. So what do you propose?
Well, in cases like you're mentioning, I would ask you for the details. Now, what are the details as to how you're going to decide? Probably the most typical example in psychiatry is suicidality. Okay, lots of patients come in because they're apparently at suicide risk. How do you know when that risk is low enough that you can discharge them, right? And if they could give me a convincing answer, fine. I know as a psychiatrist, people hide their suicide, plans, and it's really tricky. And So it takes negotiation, but I must tell you, sort of by the end, when I stopped doing managed care in the department, it was because I thought the amount of capitated money we had wasn't adequate, the way I could figure it out. By then I could figure out, well, what are we going to do for this amount of money for this population? And the money from the people who were paying for the contract seemed inadequate to me. So I said, we have to stop, or at least I'm stopping. I'm not going to manage this anymore because there's not enough money. Because we're going to be demanding people get out of the hospital in 2 days instead of 5 days in order to break even. And that's impossible. So, where to draw the line that the treatment should be let to continue because the patient still needs it in that setting. It's almost like a one-on-one kind of a ongoing evaluation. The odd thing about it is there's this, once you start doing this a lot, people know it's going to happen and they cut down themselves without you even trying, so it's kind of this halo effect. And so, for young people, young psychiatrists now, they're not bothered as much by this as us older psychiatrists became, because this is what they know. They're not going to have much time in the hospital with patients. They're not going to be able to do 2 or 3 times a week psychotherapy for months on end with most insurance contracts. It's not going to happen, and they kind of go along with it. So, it's a big societal issue also.
Okay, so more articles to write for sure. I am curious about your award, Hero of Public Psychiatry. It seems a little unusual. And how does one prepare for such a thing?
Yeah, I don't know. I don't know why I got it. It was a little tricky. So when did I get that award? It was from the American Psychiatric Association Assembly, and the head of the assembly had asked me, we're going to present this award at the next annual meeting. Who would you recommend for the award? So I gave her a couple people I knew. And this was 4 psychiatrists who worked in community psychiatry, sometimes called public psychiatry, poor people, and who, by the way, there was never enough money to take care of patients adequately. So it was like managed care by some other name, always. So anyways, I gave the name, and then I got a letter from the American Psychiatric Association saying, you're getting this award at the next meeting. It was like, I was sort of tricked, and
maybe it was a secretarial error. They thought that you were the one instead of, the people you were asking.
Yeah, I don't know, but it basically had something to do with a long amount of time I was working in public psychiatry. My clinic got some awards along the way and notoriety, and so forth. And by then I had done managed care in the public sector, despite all the controversy about that. So, when people use the word hero, it's usually you're taking a risk of your personal life to help others. So I asked, what does the word mean here? And it said, you were risking your reputation by some of the stuff you did. And for us, that counts as being heroic. And I did, that example that I was called evil by the president of the American Psychiatric Association.
Right now, is this the same association that gave you the award?
Yes. Yeah.
But it had a new president by then.
Yes. Fortunately, the presidents only last 1 year. So, and I later got another award in 2016 for administrative psychiatry, which in a way overlapped. It was partially because of the administration I did in managed care and other stuff in psychiatry. So some people recognized what I was doing may have been important to recognize. I don't know. The most the stuff I like the best, because we're talking about writing and stuff, is when what I've written seems to make some sort of dent on people. So just to mention a few other more recent books, I was the main lead editor in a series about psychiatry and different religions. 2019, it was on Islamophobia and psychiatry. Next year, anti-Semitism and psychiatry. Following year on Christianity and psychiatry, and now asked to edit one on the Eastern religions and spirituality and psychiatry. Well, I got a note recently from one of the top cultural psychiatrists when I asked him about this new project and whether I should try to do it. And he said something like, your books foretold the future, do it. So, when you get that kind of feedback, that's really rewarding, because it feels like, I was writing and editing something that seemed important over time, maybe was even ahead of its time a little bit. And that's great. That's more rewarding than those formal rewards I mentioned. So
That's great. And I will put those links in the show notes. Well, I trusted my friend Ronald Pies that you would be a great guest, and I have not been disappointed. Is there anything you'd like to add before we close?
No, I appreciate this opportunity, and there's so much thanks along the way to do this. And obviously, because I was hit with slings and arrows along the way, without the support of my wife and other family, including my kids, a rabbi son and a career counseling daughter, but especially my wife, who actually got me out of a couple of messes I wouldn't have gotten out of. Without her support and constructive criticism, this would have been the work I've done, especially the writing, wouldn't have been possible, because once the stuff is out there, especially now with the internet, there's no taking anything back. So need a thick skin.
Well, those sound like some good stories, and if we had more time, I'd like to ask you about those. Maybe next time. Maybe next time. Sure. Well, Dr. Steve Moffic, I want to thank you very much for being a guest on The Art of Medicine.
Thank you for the opportunity. I enjoyed it.
Well, before we close, I'd like to give another thanks to our sponsor, locumstory.com, a resource where providers can get real, unbiased answers about locum tenens. This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests, and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com